All right. Just wanted to let you all know that the recording has started. My name is Dr. Marie Mesidor, and I am the co-chair of Division 18's Diversity Committee, along with Dr. Inez Campoverde. And this webinar is a collaboration between the Veterans Affairs section of Division 18, which is Psychologists in Public Service, and the Diversity Committee. And also just want to say thank you to the fabulous Dr. Gail Iwamasa for making this collaboration possible. So welcome to today's webinar titled Working Towards Mental Health Equity, the Imperative Role of Cultural Humility. All questions can be entered into the Q&A box. So we'll take time at the end and sometimes in between to answer questions too. If there are any technical difficulties, please let me know by putting those questions or concerns in the chat box, and I'll attend to you as quickly as possible. I do want to introduce our wonderful speakers. We are so lucky to have both Dr. Diana Mendez and Dr. Larry Burrell as speakers today. And first, I'll give you a little bit of a background of Dr. Mendez. Dr. Mendez is an outpatient mental health program manager for the Orlando VA healthcare system, community-based outpatient clinics. She oversees the mental health programming of clinics and serves as the supervisor of all staff. She supervises psychiatrists, psychologists, clinical social workers, peer support specialists. She's board certified in behavioral and cognitive psychology and serves as a prolonged exposure therapy consultant for the VA. She's also the founding co-chair of the Mental Health Diversity Committee and as actively involved with her facility's Diversity, Equity, and Inclusion Committee. She's a Vision 8 unconscious bias trainer, and her primary clinical and research interests focus on trauma, resiliency, social determinants of health, diversity, equity, and inclusion, as well as cultural variables in evidence-based practices. She's currently a principal investigator on an HSR&D project looking at ABPP practices in the face of COVID-19 and changes. And she's a co-investigator in a study exploring social determinants of health and social isolation. She's also a subject matter expert in DEI, having provided multiple related presentations, trainings, and consultations. So we're just lucky to have her with all of that on her resume, and she's so busy. Dr. Larry Burrell, he is the Deputy Manager of Integrated Care with the VA based out in Martinez, California. He's also the Director of SECS, which stands for Sexual Education and Clinical Services Clinic. He's chair of the Behavioral Health Diversity, Equity, and Inclusion Committee, and also a member of the teaching faculty. He's a small business owner where he provides clinical and consultative services, and he really focuses on improving health equity for marginalized population in his work in an empirically informed way. He's done many studies regarding behavioral treatments related to the prevention and treatment of HIV and other STIs, breast cancer, and cardiovascular disease and chronic pain. His research right now is focused on developing evidence-based protocols for addressing gender dysphoria within the veteran population. And Dr. Burrell's work, both clinical and empirical, centered really on the role of culture in understanding individuals and their related health behaviors. And he's published in numerous journals, and he is really an international expert, and he's been an editor for several publications. So we're very fortunate to have such accomplished and talented presenters today. I'm just so excited to have introduced them. And now I'm going to turn it over to them to really lead a wonderful presentation for everybody today. So thank you all for being here once again.
Thank you everyone for joining us. It's truly an honor to be here today to talk about working towards mental health equity and where do we start, right? Sometimes a lot of this concept seems so big and we want to go back to the drawing board and really start this discussion, and we're really honored to be here. So without further ado, we'll get started. Let me see, can you see my slides? Can everyone see the slides well? Okay, perfect. Before we get started, we do want to take time to for land and labor acknowledgement. This is from the Medical Association for Organizational Strategic Plan to embed racial justice and advance health equity. We do acknowledge that we're living off the taken land of indigenous peoples for thousands of years. We acknowledge the extraction of brilliance, energy, and life for labor forced upon people of African descent for more than 400 years. We celebrate the resilience and strength that all indigenous peoples and descendants of Africa have shown in this country and worldwide. We carry our ancestors in us, and we continually call to be better as we lead this work. Dr. Burrell and I feel like this is really core to what we do as psychologists, and definitely crucial in getting this conversation started. Also, just a brave space reminder, we want to ask everyone to, just as a reminder, to commit to privacy, commit to learning. We wish to promote inclusivity and respect with today's talk. We ask participants and please be mindful of language, and to be open to consider our assumptions and our generalizations about members of different communities, social groups, like Dr. Burrell says, a step up, step back. That is totally him. Compassion for others and ourselves in this learning process. Something that we will be emphasizing today is the lifelong journey that this work takes, and the commitment that comes with that. So we're asking everyone to be compassionate with ourselves as we embark this and continue this journey, and also with others, and reminding that, as a reminder that everyone is in their own space as they start this journey, as they continue this journey, and there's not right or wrong approach. We're just doing the best we can in our own personal journey towards equity. And then we also, Dr. Burrell and I will work as much as we can to create psychological safety today as much as possible. But we also want to acknowledge that some discomfort may occur. And as psychologists, we know that's not a bad sign. That means that something is clicking, some things are happening, some processes are going on in the background. So please, I invite everyone to reflect on that discomfort and perhaps take that opportunity as a possible opportunity for growth. Dr. Burrell and I don't have any potential conflicts of interest in relation to this program or presentation to disclose. So without further ado, we'll start with talking about social determinants of health. And we plan to start kind of going back to the basics. Right. So when we think about social determinants of health, we're thinking about conditions in which we grew up, where we learn, where we work, where we live, and all of those factors that impact health. I think many times in our trainings, we think about social determinants of health as more public health related issues, items to be addressed separately from mental health. And we're hoping to really highlight how it's all interrelated, because it's all part of the human experience, and definitely, the shaping of people's life experiences, condition, etc. It includes the safety of our neighborhoods, the access to nutritious food. Can we breathe clean air? Is there access to drinkable water? Access to affordable healthcare. And many times, I think, especially when we're thinking about working with the veteran population, service members, we may think that those things may not be as applicable anymore. And, something that I would like to invite people to consider is that all of those factors are part of someone's cultural experience and their upbringing in life. And that they're really the quality of education, and they're really part of how people learn to see the world. So, if you grow up in a community where most people around you don't have access to healthcare, and health literacy is not a part of that community, and I'm picking that up as as a first generation immigrant growing up in a community with people around me didn't go to the doctor because they didn't have health insurance. That wasn't a thing. Then it's almost like it's not part of an everyday something to even consider, right? You only go to the doctor when you're very, very sick. Otherwise, you don't. And many of those things may come from limited access to healthcare, type of employment that people have, which may be then directly impacted by access of education, quality of education in certain communities. And something to consider is that all of these factors, right, all of social determinants of health really are influenced by the distribution of power and wealth and other resources across society. And you will see communities that have been historically marginalized, usually being the ones that are the most impacted. And really, this is the core of health inequity for people of different social and economic classes, genders, ethnicities. And definitely, we would see how that complexity plays out with intersectional identities. So I do have a couple of YouTube videos. I know we have a lot to discuss today, so there are quick videos that I will not play today just to not cut into the time, but it really, one talks about just social determinants of health in general, very similar to what I'm saying right now. And the other one talks about how that impacts mental health. And that one, and again, they're very user-friendly videos. And the other one really talks about how many times, maybe they don't go in as much detail, but the main thing is that as we think about mental health and we conceptually, clinically, we may think about mental health as being impacted by choices we make. But many times people don't have that many options. And those options are based on social determinants of health, health literacy, mental health literacy, so just different realities that a lot of people may not be aware of. So something to consider, again, from a conceptual standpoint, and the direct impact it does have on mental health, and how and the role that racism and systemic racism has with that. So as we transition into that, I'll let Dr. Burrell kind of pick up on that. And he and I have presented before, so you may see us kind of going back and forward a little bit to add. So just whenever you're ready, Dr. Burrell.
Yeah, that'd be great. Thank you so much, Dr. Mendez. And of course, everyone for inviting us here today. Really appreciate that. To continue on, so we were talking about the social determinants of health, and we also thought it would be remiss of us if we didn't talk about explicitly some of the institutional disparities. So social determinants of health, how your identity impacts your life. How does this show up in a systemic level? What are some of the things that we would like folks to be aware of? And that's what's depicted on the slide here. So starting on the left-hand side, we just kind of, well, first off, I guess it'd be easier to read this top down. So what's up top are all the various institutions within our society, of course. So we have economic institutions like our neighborhood institutions, education is an institution in and of itself, food security, et cetera. And then because of racism and discrimination, as indicated on the gray bar there, we have all these inequities, disparities in these areas, so employment, income, et cetera, leading to, down here in the orange bar, health and well-being, morbidity, mortality, decreased life expectancy, et cetera. So for us today as psychologists, obviously most of this stuff is going to focus on the healthcare system, the content of our talk today, a lot of the examples that we'll be pulling from. And as we're continuing to have these conversations, please, please, please keep this slide in mind. Because while we do have the very, very real and awesome responsibility of getting to work in the VA, and that's great, and I love it, we're also still psychologists, right? So that means that we have the opportunity, if we want to avail ourselves of such, to intervene in any one of these other institutions. There are things that you can do, for example, writing your senator, emailing your, not on your VA time, but email your senator to let them know like you're concerned about X issue. And I think that's important for us as well. We need to be mindful as psychologists of our power, of how we can exercise that effectively. So that's what we wanted to share with this particular slide. Could we move on, please? Thank you. So the next thing to talk about that's kind of foundational and really important from our perspective is intersectionality. So we've talked about social determinants of health. Again, the idea that who you are confers certain outcomes for you in terms of health. And this can be positive and negative. So folks out there may be familiar with the idea of blue zones. These are places where people live to be in excess, typically of like 100 years old. Typically found in Japan, I think, and there's some in Utah and things like that, where Mormon culture doesn't allow for like consumption of coffee and alcohol and things like that. And that's really important to know, but you'll listen, the example I'm giving you is really kind of centered on one particular aspect of identity. The most recent one, of course, there being Mormonism, right? And that reflects religion. Now, the cool part and the interesting part is when you start to kind of overlap these things as depicted by the figure that you're looking at now with this kind of Venn diagram feel that we're giving you, you get even more refinement and more determinants factoring in. You can think of it as like a regression equation, basically. I know, I'm sorry, I didn't mean to mention the regression word. And it's like this plus this all together to explain this outcome. Each one of these things are really just variables. And it's important that we're mindful of each and every one of the variables, just like you would be in any standard regression model, so that we can get some outcomes that are really important. Can we hit the next slide, please? Great. So in addition to understanding a little bit more about intersectionality, we want to understand how that plays out. And to do that, it's really helpful to just be aware of the various identities and the levels of power they confer. And that's kind of what's depicted on this power wheel, if you want to call it here. So basically, long story less long, the center of the figure, where it's labeled power, is the place to be. That's where all the cool kids are hanging out, right? Now, that's fun and that's great and that's all well and good. And what happens if you're on the outside of that inner circle, in the marginalized circle? That's going to confer you less power, less ability to enact changes in your environment and for yourself, and relatedly, some health disparities, potentially. And I think that's really something important to note. When we say social determinants, it's the overall, the collective, the likelihood of, you know, this particular outcome being there for you is exacerbated by your identities. Inevitably, you'll have a veteran or client or patient, depending on which particular model you're working under, that says, I have identity X and experience Y did not happen to me. You'd be like, great, that's awesome. I'm so glad that you got to not be a statistic. And by and large, what we're seeing for everybody is that these are some of the things that we can expect. So please try to hold that in mind at the same time. The idea that like the likelihood of having, because the other part of it too is even if you're completely you're a young, straight, white male with all the power and all the, you can still have difficulties. You can still have problems and all the other things. So we're not trying to necessarily say that only marginalized persons need to be considered in this example. Quite the opposite. This is an effective framework for looking at everyone and having everybody's identities kind of show up in their work. For example, I remember once when I was working, doing an assessment on liver transplant for an individual who presented as white and was white. He told me, you know, because I like to be standardized and kind of offer the same questions to everybody. So I asked him, can you tell me about any experiences of racism? Fully aware that, yes, he very much presents as white. Interestingly enough, though, he started sharing with me about how his ethnicity of being Irish was conferring stigma relating to people saying like, oh, your liver problems are all about your drinking. You know how you Irish folks are. So again, the idea here is not that we have to, of course, Dr. Furk will be happy to share the slides at the end. The idea here is not that, you know, only marginalized persons are at risk of social determinants of health. The idea, of course, is that we all are. And that's why this stuff is important for us to kind of be mindful of and know how to navigate effectively. So I'll just pause there for now. And
I wanted to add that absolutely, and something to keep in mind as well is that, you know, that we want to be mindful of the stimulus value that individuals have in addition to intersectionality in the broader context of social determinants of health. So even when we are navigating the world in different places, even though, obviously there would be different identities that would put individuals in different places of the spectrum. There may be some that have more dangerous or heavier implications than others, especially those that may be historically loaded with hatred, acts of violence, etc. So just kind of asking individuals to be mindful of that as well.
All right, so now that we've talked about what social determinants of health are and some of the factors that mediate and moderate that, let's think even more broadly about what are some of the factors that maintain specifically mental health disparities. So try to do a job of listing them here on the slide. This is pretty good, but I would argue maybe not necessarily comprehensive. So feel free to share with us in the chat if you'd like any additional ones that you'd like to consider. And as we conceptualize it, and from our review of the literature, the few that we wanted to talk about are as follows. So implicit bias, hopefully everybody's familiar with the term, but it's for those of us that may be in a different space on our learning journey. Implicit bias refers to the idea of, the things that you don't, explicitly say. So it's anachronistic, I guess, to call it like, or actually another way of looking at it would be unconscious bias for those of us that like to get psychoanalytic on things. But the important part is if you were to explicitly ask someone and they say, are you racist? Do you engage in these activities? I'm like, no, I'm not racist. I love all people. I don't see color. That's another one we get. And then you give them certain tests like the Harvard implicit bias test. And we see, well, based on this, that, you have a preference for, just to make it easy, white people or men or any other group that's in power. And the problem with that, of course, is that when folks are showing up for their treatment, if you don't have that powered identity, you may not get the most effective treatment that someone else from one of those powered backgrounds might. And there's a bunch of other different reasons why power and privilege in medical settings is important, but that's just one off the top example. Mental health stigma and negative beliefs, which are exacerbated or I would argue more prominent in communities of color. And I say that intentionally. It's not just about Black folks, although I know that the literature has often, problematically so, I would argue, created this artificial dichotomy of just Black and white's always the referent group. And that's a whole separate conversation that's problematic. The important part is that stigma exists for a lot of different identities. And that's something we need to be mindful of if we want to address this mental health disparity gap. Silence gap in the comfort levels of mental health providers processing and addressing racism. Yeah, that's definitely a thing. Honestly, shout out to you all for being here today to even talk about this stuff. And I would argue, like, within the VA system in general, work like, Asile Hubbard's doing, or Maurice Inslee in their race-based, or our own Ivy Hall here at Northern California, doing their race-based trauma and stress groups. That stuff needs to be rolled out a little bit more often, if for no other reason, because I get a lot of referrals about, Dr. Burrell, can you do this? Can you help with all the things? And I get it, we're all strapped. The VA is a kind of resource rich and poor simultaneously place. And I think one of the effective answers would be, yes, I'm more than happy to help. And here's some additional resources that the VA should be providing you to make sure that we can all address that. The last few hopefully are a little bit more straightforward. Language barriers. So if folks are speaking different languages, or even if you're speaking the same language, but using more colloquialisms and things like that, or don't even understand some of the aspects. So for example, I identify as queer, and in the queer community, we throw shade, which is basically insulting your friends in a funny sort of way. In the Black community, we have something similar called playing the dozens and all the other things. The idea here is, though, if you are unaware of those like cultural norms and mores, you won't be able to provide as effective care, and then the mental health disparity persists, in addition to obviously the differences between speaking English and Spanish, for example. Lack of diversity in treatment providers is another concern. I think that in terms of not just race, though, we want to highlight, again, thinking intersectionally, sometimes not having enough male providers in psychology, I think, would be one of the things. Definitely not having enough, Black men. I'll speak to that. There's APA data out there that shows what the numbers are in that regard. But those are some of the things to think about, and other things to consider as well. Ability status. I don't think I've ever had the opportunity to meet a psychologist with like a mobility impairment or things like that. They would perceptibly be able to kind of engage a little bit differently with some of the veterans that are managing those issues as well. Cultural beliefs regarding mental health, I think that kind of dovetails nicely with what I've already said about stigma, and then reduced economic resources. Perfect example is kind of the life that we're living out now. I also, like was mentioned in the beginning, have a private practice, and some of those folks that I see, literally I've been seeing for years at this point, simply because they have the money. It's not a disease-based model. We're actually focusing on the wellness model. Because you have X number of dollars that you can throw at me every week, month, year, yeah, you get to have this additional benefit. Where there's other folks who would probably benefit more from the services I'm providing, but frankly can't afford it. Luckily, the VA, does efforts to like buffer that. And I think overall for our culture in the system, there's definitely a lot of problems with that. And I'm not mad at all of us as psychologists. Medicare, Medicaid doesn't do a great job of reimbursing us, and we have to be mindful of, our own bottom lines. I personally like having a bed, so I want to make sure that that gets maintained. At the same time, those reduced economic resources systemically are definitely problematic. And of course, lastly, inadequate or inaccurate diagnosis. And that's when we see things like, the inappropriate labeling of women as histrionic. I think from this history was a really big example there. Hell, like not even too long ago, I think it wasn't until like 1970 or something, when the DSM finally removed homosexuality, and they still called it homosexuality then, from the DSM. So that psychology in and of itself is informed by the culture. And because of those cultural biases, sometimes we promote the very thing that we're trying to work against, which again, inaccurate diagnosis, inaccurate treatments, etc. So those are some of the points we were hoping to share there. Anything you want to add, Dr. Mendez?
No, I think that sums it up really nicely. And as we're transitioning, right? So we talked about some of the barriers, and really with the goal, it's reaching mental health equity, and really being able to provide quality access to care to all individuals, regardless of their social determinants of health, regardless of their economic background, sexual orientation, gender identity, geographical location, access to education. And many times what happens is that we get caught up on the big systemic part. So we start thinking about how the employment part, or and obviously to the VA we have many programs that do address housing issues. We are creating different bridges to work on helping veterans have access to services in terms of helping with proximity to care, through either virtual care, doing digital divide, giving them iPads, like we're making as a system, we're helping with that. But from a psychologist standpoint, I think many times we may get into the bubble of I provide treatment, this is what I do, and all of those determinants of health, all of those factors are so out of my control that they're kind of like out of sight, out of mind. And what we want to do, and part of the reason why Dr. Burrell and I thought of this presentation and talking about that, is that all of those things obviously have an impact, like we talked about earlier, in options that people have, things that people would even consider trying, and overall health outcomes, including behavioral mental health. The problem is that we know that, but we continue to witness significant disparities in terms of prevention efforts for mental health, screening, diagnosis, and we see that even more so in our ethnic and racial minorities compared to majority group counterparts. And so where do we start? And I think this is kind of one of the biggest questions that we get, right? So what can I do? So I'm just a psychologist. I can't change the world. I can't, bridge this huge inequity gap. How can I make things better? And it's a huge task, but I think it's important to consider how we can all be huge bridges for that inequity gap. in different ways. And we start, one of them is that it requires seeking understanding of all the systemic intersectional determinants of health variables that we talked about it at a social ecological level that we mentioned earlier, and how they inform culturally informed care. When we think about, unfortunately, I think a lot of our field has gone into, and I think we're pulling away from it, kind of like I specialize in this type of minority mental health community only, and I'm like the expert, right? And some of the issues that we face with that particular model is that we, cultural comes through different lenses, right? And can you see my slides? Okay, perfect. And with the veteran population is, again, the intersection of all the identities that we mentioned earlier, life experiences that people had based on different social determinants of health, and which include as well ethnic, racial, etc., and how institutionally communities that have been historically marginalized have been impacted by that, and how has that then impacted the person's mental health, and where do we stand in terms of treatment? So something to caveats to consider as we embark this process is to consider again that everyone has multiple identities. And something that we see a lot with what I just mentioned is that we see a lot of, many times within group variation is minimized, and between group variation is exaggerated. So individuals from one particular group are all kind of seen as one collective, minimizing a lot of their variability within those groups. And I think that's when we lose the actual person. And again, to be mindful that culture is a context, and it does not define an individual, right? So it's just the context of the person. It's not the person, it's not everything that the person is. So again, going back to where do we start, right? That big task, and we go back to how do we include all of this information, right? We go back to case conceptualization, we go back to how do we see the person as a whole, and we go, of course, we want to be mindful of diagnosis and how does that impact care, but we have to also consider all of the things that we mentioned in terms of their life experiences and their exposure to access to variable things, mental health literacy, resources, and just options in general. So we invite everyone to then transition to going back to the beginning stages, right? And going back to self-identity and introspection, and really see where we at, and learning from everyone. So we're going to talk more about cultural humility for the remaining of the session. And this is kind of where it fits in, right? So where does cultural humility fit in this big picture? And this is where it is, that based on our stance, based on what we see, when we see a person as a whole, we consider everything that their life has been. And we're able to really honor their truth, and we learn and we identify all the things that we don't know, and all the things that we wouldn't even think about because they're so foreign from our experiences. So I will now pass it on to Dr. Burrell, who will talk more about the difference between multicultural competence versus multicultural orientation. And this has been a shift that we have seen lately. And we'll be adding to that. So Dr. Burrell, take it on.
Yeah, I think this is important to kind of answer the question that we're posing to you all is, what do we do? And the answer is right here. So if you ain't paying nothing else, if you're over here on the West Coast right now, take a second, swallow what you're chewing, and pay attention to this slide. So like Dr. Mendez was already discussing there, the idea becomes that historically we focused on competence. And that's great, and that's cool for like 1995. The idea with competence was there's a checklist, a box of things like you should learn and know and do. Like a common example would be, if you're not Black, don't say the N word, those types of interventions and things like that. The problem with that is again, it ignores and negates kind of to a degree intersectionality. And like Dr. Mendez was talking about a little while ago, the variation within a group is way more extensive. And this is, sociologically, biologically, but the variation within group is way more extensive than it is between groups. So for folks to simply learn the rules to not be racist is problematic at best. That being said, of course, like we talked about right at the top of the hour, we're all at different spaces on our learning journey. So my intention isn't to shame anyone. If you're still in the space of kind of learning the rules, that's great. At least you're on the track and on the journey. There's people still further behind you that aren't even interested in knowing that the game exists, let alone learning the rules. So I do want to acknowledge that people can be in different spaces. And this isn't a judgment thing about just wanting to be clear on what we're looking for moving forward. Which brings me to the point of multicultural orientation or cultural humility. In contrast to learning the rules, this is more of a way of thinking, a way of being, engage in, of course, at least minimally your clinical work, but arguably, spoiler alert, it does kind of spill over to the rest of your life. Next thing you know, you might be thinking about like all this other stuff, or equity in the grocery store and where different places you can go to learn more about culture. But for now, we can just apply it to our clinical lives, and that's okay too. So basically the idea is, like it says here, the helper's way of being, others' way of being based on philosophy regarding the value of culture in people's lives. Now, that's really easy to understand empirically and all the other things. And of course, from the literature, we can see in the numbers very clearly these health disparities exist. And that's helpful. But I think that, again, the real important part here is the cognitive shift of not just knowing that these things exist in the numbers, but understanding the real life manifestations therein. And if you don't understand them, taking concerted efforts to do so. And that's what we're looking for here is cultural humility, core facet of a multicultural orientation. So as we continue to think about what humility means, we want to kind of look at it in two different facets. It's the interpersonal and the intrapersonal. So intrapersonal inside yourself, interpersonal between two different folks. And intrapersonal for me looks like a lot of different things. If you've heard me talk before, you probably heard me say something to the effect of, everybody's racist, me included. And that's my own intrapersonal cultural humility manifesting. I personally kind of conceptualize it like we're all going swimming, right? You can't go swimming and not get wet. America itself is this pool. The world arguably is this pool wherein there's just certain cultural norms and they sleep in. I've taken the Harvard implicit bias test myself, and sadly, apparently I have some problems with Black people, which was really quite concerning. But again, it's not necessarily my explicit, it's the implicit from the culture that you kind of absorb it as a sponge. But having an accurate view of oneself so that you can proactively address that by having conversations with colleagues, by just being aware with yourself of like, hey, this is a problem for me. Here's some things I can put into place is really important. The interpersonal, of course, is the same process, but just including, I think, a little bit more complicated because you're thinking about other people there. So as indicated there, other-oriented rather than self-focused, characterized by a lack of superiority towards and respect for others. So basically the idea that we can all learn from each other about various aspects of our culture. Now, how we go about that and when and if we choose to go about that is another conversation. For folks from marginalized backgrounds, we want to avoid taxing the minority tax. Hey, tell me about your culture. I myself, to get to this position, I've gone to a class or two, and every now and again you get put in the place of having to speak for all the Black people or all the queer people, and that's not what we want. Like, we want to form relationships with folks where A, they feel comfortable sharing, and then B, we're respectful in instances where, like, somebody could help us fill in a learning gap and approach them as if they're giving you the gift that they are giving you, which is that emotional labor and everything of helping you understand what their experience has been. Not everybody gets the opportunity, like I did, to take psychology of women or African-American psychology to learn these things. And we have to balance that out so that we can be as effective as we can be in our various positions.
I wanted to add, Dr. Burrell, that a lot of times a way in which well-intentioned and maybe non-intentional superiority or how this comes up may look like someone who has not gone through a certain experience telling a member of a different community how they should act in a certain situation, how they should feel, how they should respond, what someone else told them based on their opinion, and based on that, then they're telling you how you should act in that situation, right? Because I will say that the core too of cultural humility is understanding that this is something that perhaps there isn't someone that is an expert of their experience other than the person living that experience. And that we need to recognize that even though we may have a doctor title next to our name, even though we may be subject matter experts in trauma treatments and this or health psychology, you know, when it comes down to someone's reality, life experiences and day-to-day life, we cannot tell them what that experience is like or how they should feel. And it's a huge reminder, you know, is that what it could be a cognitive distortion for you or something that seems completely off to you. It's very well likely a true experience for someone else. And that is totally okay, right? So just some things to keep in mind when we think about the interpersonal piece, that those are ways in which sometimes we see that happening in the clinical work that we do.
Agreed. Yeah, I definitely view our job as like, you know, like I've said to literally thousands of veterans at this point, my job is to combine the knowledge I have of like psychology and behavior change with your knowledge of yourself so that we come up with some unique outcomes. And that's what we're looking for there. And another point that I just wanted to make on how to do this, that Dr. Mendez just kind of stirred up for me. We also want to avoid, when we're trying to engage in cultural humility, what we call equivocating. So Dr. Mendez was basically alluding to what's colloquially referred to as mansplaining there. No disrespect to my other fellow like male identified folks out there, but yeah, it's that idea of like, oh, let me explain it to you, sweetie, because you don't get it. Similarly, another problematic thing that occurs is when somebody from a powered group says, oh, I have that same experience too, because, you know, I was discriminated against and something like that. And it's like, you're not. And that's really important. Even if you totally in your genuine heart of hearts believe that's true, in our clinical work, we have to be mindful that the other person, it's about them. It's about treating them and question whether or not that would be the most effective strategy. So yeah, I guess take home point here is desire and ability to maintain. So we understand what cultural humility is, but like I just kind of got to there, it's the idea again of it's about the other person. If we wanted to, and I know critical race theory is a bit of a hot button issue sometimes, but that's another thing that's talked about there, centering the experiences of the marginalized individual to help them do better. And that's what we're looking for there. So like we talked about here, this is a kind of overall thing on how to engage in cultural humility. You want to take some time to reflect inward on yourself and be real with yourself. In fact, there's quite a lot of literature, and like, I don't know if anybody picked up on it. Sometimes I make jokes, honestly, just for myself, folks. I'm not even gonna lie. But one of the ones I just made there was this idea of like, there's a paper out there, several papers that talk about being colorblind and how that's, you know, initially that was a good thing. Oh, we don't see color, everybody's all the same. In actuality, what this paper and several others show is that folks that purport to be colorblind actually provide less effective care. So all that to say, when you are attempting to be culturally humble and having that inward self-awareness, like, okay, fine, you're not racist and you're colorblind and all the other things. Let's not define ourselves in what terms we're not. What are we? Are we actively anti-racist at this point? Are we feminists or whatever other, are we a good ally? But having that conversation with yourself and reflecting inward is arguably essential. I say arguably because you can also be open to other folks, bringing us to our next point, giving you that feedback when folks will tell you like, hey, this is how that landed with me. And, just you can take that information and do what you want to. Again, I would encourage you to treat it as a gift, really kind of wrestle with a little bit and see if there's something to implement there. But again, the outward thing, being mindful not only of your intention, but the impact that you might be having on individuals. And then lastly, and arguably, upward growth and effective clinical treatment. The idea of not allowing ourselves to rest on our laurels. Like we all heard the book-long CV that Dr. Mendez has and how accomplished she is, and yet she's still here giving this talk. And to be quite honest, I hope it's okay if I say this out loud, Dr. Mendez reached out to me as someone a little bit further behind in the professional pipeline, as it were, to provide this opportunity for me. So clinical growth and effective treatment, not only does it apply to our clinical work, as evidenced by the example of Dr. Mendez, this can apply to administrative tasks as well as professional development tasks like the ones that we're currently engaged in. So thank you for doing that, Dr. Mendez.
Thank you. And I wanted to add to that, that it does sound kind of like fluffy, and I just see myself as Diana. But that the even with all of that, right? When I put some sweatpants on and I go to the grocery store, I'm just another Latina girl that is asked whether I'm paying with food stamps or not. And it's a true story. It happened to me right here within the last year, right? So just to consider that just because we may hold a position of power in one role, it doesn't mean that our stimulus value changes when we go to other places. And kind of going back to what our reality may be like, right? I can share that with a colleague and someone will say, oh, wow, I wouldn't think about that. And somebody else will say, oh, I'm sure they didn't mean it, right? Trying to tell me how I should feel about the situation when I just went through it. And I was actually confused because they don't call it food stamps anymore in the state of Florida. They call it EBT card. So I went to pay and they asked me if I was paying with an EBT card. And I was thinking my debit card. And I explained to the cashier, no, I'm playing with my debit card. And she was like, there was this like awkward miscommunication because clearly we were not talking about the same thing. And I was obviously missing the part. But again, just kind of as a reminder, right, that a lot of things don't matter, but with our who we are counts with us, and all our stimulus value gets carried with us wherever we go, and people would, be reactive to that. And there may be things that some have to consider when they're raising their children, when they're relocating, where they're thinking about advancement opportunities that other people may not have to. So even when we think about cultural humility, all of those things are, I think, things that are important to keep in mind. That cultural humility, by definition, again, is larger than ourselves. And I don't mean to take over your slide, Dr. Burrell. I know we're kind of.
This was yours.
But just kind of making that comment and that reflection. I know we're kind of heading towards the end of the hour, and we had some vignettes and some of that. So I don't know, Dr. Burrell, how you want to maximize the time we have left. Do you have any thoughts? You want to go to the discussion questions?
Yeah, I wanted to make sure we had some space to answer any particular questions or hear feedback from anybody out there in TV land. You already have all the slides. The only other things, we had some vignettes, but apparently we were feeling a little chatty today, and that's okay. But yeah, we had some vignettes, and the point of those was to, vignette number 1 talks about basically somebody from a powered in identity. In vignette number 2, we switched it and changed some of their identities to be less powered. So you can use those to carry on some of these conversations at your local VA. Yeah, as you're noticing there on the slides, the things that are highlighted is how we gave them less powered identities. But we don't need to do that in this space. Just wanted to see if there's questions from the room or comments or feedback. I'm reading some of them. Thank you, Dr. Iwamasa. I'm glad to really basically bottom line in the day, I just want to not disappoint Dr. Iwamasam. So as long as she's happy, we're good.
Same.
Oh, thank you, Dr. Kim. Appreciate that. We try our best.
Well, I was going to go into just talking about next steps and CEs, but thank you both, Dr. Mendez and Dr. Burrell. Awesome, amazing, wonderful presentation. I really agree with all the comments in the chat. I could listen to you all for like a day workshop. So thank you for your wisdom and for being with us today. Wonderful discussion. And thank you all of our participants for being with us this afternoon and really focusing on something that's very important for our field. In the chat, you'll notice that I put a link in there. So you'll see that there's a SurveyMonkey link, and it's asking you to complete that by May 1st to please fill out that survey. CE is going to be 1 CE credit for this webinar, and it's free to Division 18 members. The fee is $15 for non-members, and payment can be made to Division 18 PayPal account that's listed there. So if you do that, please allow up to 3 weeks to receive your CE. And everyone who registered will receive a reminder email with these instructions in about a day. So just wanted to make sure everybody was aware that that information is in the chat. I'll put it again, but I'm going to turn it back to Dr. Burrell and Dr. Mendez. And especially if anyone has any additional questions for them, please feel free to unmute yourself and ask away.
And also, please don't feel obligated to ask questions. Like we said, part of this is cultural humility. And I don't think either of us necessarily would identify as an expert. We're very happy to hear you all's experiences as well. And I'm seeing some friends and colleagues in the chat. I know we got some expertise in this room, so.
Thank you. Yeah, I agree. And I think, Dr. Burrell and I think, try to make this as conversational as possible as well, so that it can be interactive and real, right? Like Dr. Burrell said. Yeah. Well, thank you everyone for your time and for honoring us with the space and opportunity to talk about this. It's truly an honor.
Yeah. If there's stuff that comes up afterwards, feel free to shoot me an email, larry.burrell@va.gov. And again, thank you for the time and the space to come and share some of these thoughts with you, ideas. Oh, Dr. Kim was asking a quick question. Any quick vignette on dealing with white fragility responses in colleagues?
Ooh.
Ask about, you want to go first or second?
Well, my process, I'll share my process. I try to I try to breathe first, so I can have an empathic understanding and not reactive, because I've gone through that as well. And I try to personally, right, and I think everyone will respond in a way that feels genuine to them and where they are in the journey. I think I will go back to a little bit of clinically, right, to some DBT basics, like you validate what's valid and you don't validate what's not, right? So you can recognize that someone may have a difficult response to something that is happening, and you can empathize with that, but it's not, I think, our responsibility to carry or hold that for that person. And neither is our responsibility to soothe that person. So I try to validate what's valid and redirect them. So some resources or ways where they can actually continue their journey of self-actualization and actually awakening to some realities that may feel so foreign to them, to the point that they're responding in that way. And I just sit and I love PE, right? So I kind of stay with my imaginal exposure stance. And I just allow the person to sit with their discomfort and say, bye, have a great day, I have to run. And then I process with someone, and that's the most genuine response. And then I process with someone, kind of like my own reaction, but I try to do that as much as I can. Yeah. So, Dr. Burrell.
Yeah, considering you're one of those people I turn to process some of those things with, yes, I can attest that is definitely your process, and it works for me as well. Only other thing I would encourage people to consider, in addition to what Dr. Mendez was just saying there, well, first off, I want to highlight, underscore, and italicize the piece you said as far as when you have the energy. Again, we want to be mindful and being collegial and all the other things, and I think psychologists in general have this bias to like, as much as I can, and I want to give up everything and sacrifice. And sometimes you just ain't got it. And it's okay to be like, I ain't got it. Yes, ain't got it. And then, that's okay. To add to that, the other thing, when you do have it, I think another thing to consider, in addition to everything that Dr. Mendez was saying, was to create a bit of equivalence for that. Obviously, we're not necessarily going to label it as white fragility, because that would be problematic, I would imagine, for the individual. And this is in contrast to what I was saying before, when I was saying don't equivocate with somebody that is from a marginalized community. So I myself, I wouldn't talk to some woman saying, oh, I understand your experiences as a woman because as a man, I experience blah. However, working with colleagues, I've definitely had the opportunity to say something to the effect of, my understanding as this aspect of your identity that isn't as powered and all the other things, you might have these difficulties, and ergo, you can maybe help them understand a little bit about how race is just a different variable. They might be an older adult and having difficulties accessing something because of that, but then helping them understand, because of the age bias, that other types of biases also exist and we can intervene effectively, would be the only thing I would think to add to what Dr. Mendez was saying. But you're right, Dr. Kim, it is a full day workshop. I know we did one before and we still didn't come up to an answer to that question. But this was fun, y'all. I'm seeing it's the top of the hour though, so I'm gonna step back.
Yeah. Thank you again. Sorry, Dr. Mendez.
No, to say thank you.
Yeah. Thank you again to our wonderful speakers. Just want to remind you all to complete the CEs, and also the recording and slides will be on the VA section webinar page in a few days. So thanks again and enjoy the rest of your day.